abdominal binder. I talked to you about it in the lecture. One of the purposes of the abdominal binder is that it actually can increase the pressure, so it can help with two things: orthostatic hypotension, and also even with coughing and breathing. Okay, because it kind of acts as abdominal brace, so to speak, when you don't have abdominal muscles. So, typically a spinal cord injury patient that especially is upper cervical or upper thoracic will put an abdominal binder on. What else will we put on them to keep them from having issues with orthostasis? What else did I say? Head stockings or ace wrapping the lower extremities, something that's going to maintain pressure. What are we doing when we get somebody up for the first time? What are we monitoring?
Vitals.
Vitals, thank you. And how do we get them up? Look, we're in the acute care setting. We're going to go into the room. How do we start to get them up? What's the safest way to do it? Raise the head of the bed. Raise the head of the bed with their legs up. Take their blood pressure. Wait about 3 minutes. Make sure that it's staying stable. And then you can kind of bring their legs over the edge. Now take it again. Wait 3 minutes. Let's see how they're doing. Okay. Or you can, when they're in a long sit position, you can actually transfer them into a wheelchair. Take it when they're in the wheelchair and then lower the legs with their elevated legs. What kind of wheelchair can I put them in to get them used to being upright? Reclining wheelchair with what kind of leg rest? Elevated leg rest. Good. Okay. Again, to maintain how much of a drop are we concerned about in blood pressure?
20 millimeters of mercury per systolic.
Good. Okay. So moving on then, stretching. We want the patient that has a cervical lesion loses certain muscles in their upper extremities, and it depends on the level of the lesion. But typically, patients they get very tight chest muscles, and they have very weak scapula muscles. So they tend to get into this kind of posture, which you can see does not, will not help breathing at all. So the stretches that we can do to help them, we can use what?
Rows. Wait, so you want to open it up?
Stretching.
Oh, stretching. Door stretch.
So what next? I couldn't say the next. The pecs, the chest, or the stairs? I'm just going to throw that out. Actually, that is true. They will get through this position also. So you can work. And again, the scalene, cervicoplasmastoid, upper tract, those are all accessory muscles for breathing too. So that is possible that you'll get into that position. So you're not wrong, which is why I said what necklace. No, I said that. So show me a chest stretch that you can do with this kind of patient. How would you start? You're in the acute care setting. You walk into a room. You're going to treat a patient as a spinal cord.
Me?
I wasn't looking at you, but okay. Since you said me.
Are they laying down on their back?
Yeah, lay him down on the back. We're going to do it in.
Can you set them up or no?
Sit him up how?
Like sitting? Can they sit? No, like on this edge. Can they sit on the edge or no?
Well, think about it. There's cervical lesion.
Okay, never mind. I didn't know. I just thought.
Set.
Yeah, that works. That's perfect right there. You can put a bolster or a towel under them and have them. And you can put their arms down.
I'm just thinking about the bolster. Probably wouldn't go that way.
A towel up underneath.
Could you do it without anything? Just like
so
this?
retract the shoulder more?
Yeah, you can do that. What you're doing, you can position them so that they're stretching different techniques. So So tell me what you're stretching.
Low. Bottom. The sternal one. More like, you know, not the clavicular one.
Okay. All right. More.
This is the middle.
Okay.
Top. Clavicular.
Okay.
I know that one.
All right. Okay, so now someone grab a reclining wheelchair. And let's do it in a reclining wheelchair. Show me a pick minor, because I want to see the pressing.
You want to see the what?
The pressing thing. The pick minor.
The thing that Dr. Tito showed us.
Yeah, you did. Yes,
No,
you did.
that was Dr. Tito.
No, you
No.
were trying it.
No, the one you tried with you.
I did try this. I saw it on YouTube.
No, this was a long time ago that she showed us.
You sure that wasn't a massage technique?
No.
Which one?
It was a pec minor stretch.
Okay, show me.
Here.
It's like down and in, right?
You're thinking, no, you're thinking of what she
I
showed
remember
the other
Tina
day.
showing us. I don't remember her showing us.
Oh, really?
It was Tina.
Yeah.
Because I remember we asked her right before practical, and she's like, I have no idea, don't listen to me.
That sounds about right.
Sounds about right. That's exactly what you said.
Okay, so the tipping, I did show you that one. I did show you that one.
Yeah, you remember that too.
Because it pulls the shoulder this way, so you want to push it back this way. Yeah. Okay, so, but you showed me something different.
Yeah.
Maybe I was trying to show you that,
Here?
Oh.
Yeah, let's put like pressure like right in here and stretching the muscle down.
but I was laying down.
Yeah,
Oh,
just-
so you are pushing the scapula down.
Oh, you're not pushing the scapula down as much as you're
I'm
pushing
laying
the edge
down.
of the muscle.
Work in process.
Underneath in the
So
armpit.
that's like a trigger point.
It's deeper,
Like this.
right?
So I'm like this.
You can go under and start.
I thought
My
that was-
goodness.
I don't know, but it's underneath the
Yeah, like mine.
Yeah, you can go in and put deep pressure on it. That's more of a myofascial type technique. You can get up the pec up and out of the way, and then kind of put pressure on it. That's like a soft tissue technique, but this is a stretch. The pec minor is hard to stretch, but that's one way of the kind of unwinding technique. Yeah, I did show that. I didn't show, there was some pressure thing that you guys were showing. I was just curious. Where does the pec minor attach? Or where does it
process
go
of
to?
scapula.
Rockoid process, and where does it come from?
Comes from the 3 to 5 ribs.
Okay. So what can we use to assist us?
Stretch it up.
Breathe in. And she's right. If you have someone breathe in, it raises up, and if you go out, it descends. So as you stretch when they're exhaling, the ribs are kind of moving down away from you, it adds to the stretch. You understand? Yes?
Yeah, just
Yeah, okay, I'm looking right at you. I'm just looking right at you.
So would just the stretch that Brenna did be acceptable to do?
Yeah, that'd be fine. That would be fine.
What was that one called again? The one that.
There's no name. I say it
Pec
unwinding
minor.
because it takes because of where it attaches on the rockoid process, it approximates the ribs. So it basically takes the scapula and it tips it. So that makes you kind of like this, round the shoulders. So what you want to try and do is unwind. And then have you take a breath. So take a breath in and then go out. And that will add to the stretch. So I try and bring the scapula more downward and back as she exhales. Do you understand? So I'm moving away from that area. Okay, show me then. Where's my wheelchair? Oh, there it is. Show me how you can stretch in the wheelchair. So, where's my whoever.
John?
Come sit in there. Oh, Pat. Pat, come sit in there. since you broke it. And somebody stretch. Find it back.
I don't know how
Yeah,
to fix
there
it
you
out. Like, go for a ride. And me stretch him, not him stretch himself?
Yes.
Brakes in this thing?
I wonder if it turns. Bring your arms like face here.
And how would you time it with the breathing?
On inhale, I would pull back. Just to make a more of a stretch.
When you exhale, he's going
Yeah, she's going up though. Right?
Well,
That would be
No,
eating
you're
you, you're
thinking.
opening up.
But it's stretching here, and then
But we
you,
can
you get
pecs
more.
or pec minor? Pec major? Middle pecs?
Yeah.
Yeah.
Does that make a difference when either peck if you do it on the inhale or exhale?
I think it would be pec major more inhalation. What do you think, Doctor?
You're expanding.
I go with,
Where
I go with,
You're
going
exhaling,
in,
you're stretching too.
so when you exhale, it's coming down.
You're trying to bring
and
in,
you're
you're pulling out.
pulling out against the wrist coming in.
Because that's how I see it.
You get more range of motion.
I get what you're
take a
saying.
deep breath. Do you feel that more? Or?
I thought on maybe an inhalation.
So do you, which one do you feel more?
Wow.
When you blow out. So it is when you blow out. So when the ribs move away from you. It's, the ribs are descending and internally rotating. Okay. So, and you wanna. That's all I can say. So you want to make sure you're stretching those anterior chest muscles. What other rotator, this is what other rotator, shoulder rotator do you think would get tight? Yeah. So you want to make sure you're also getting external rotation. Does everybody understand that with a forward posture?
Yeah.
That you internally rotate. So, okay, so you want to watch for that. And then of course, the accessory muscles of breathing would likely get tight too, so retractions and supine, if you're able to do that, that'd be awesome. All right, so that's range of motion. Now there is a book that I posted in your doc sharing that is range of motion. It's for families, and it literally goes through an instructional manual for range, so for passive range of motion for families to do with their loved ones. For all areas of the hip. So I'm going to show you basically what it says, because passive range of motion is important to start early to increase joint lubrication, prevent contractures, etc. You all know what range of motion is for. So what would be my concern with the upper extremity, if she's completely flaccid? We've already discussed this a little bit about stroke.
Subluxation.
Subluxation, but also impingement, right? Impingement. So when I go above 90 degrees, I need to make sure that her scapula is coming with me. Okay, so that she's not impinging, because the last thing you want to do is bang away at someone's shoulder that's going to need their arms to propel a wheelchair. Okay, so you want to make sure, especially with muscle imbalance, they can be very prone to developing shoulder pain or rotator cuff tear. So you want to make sure that that scapula is coming with you when you do elevation overhead. And to a lesser extent, when you do more the abduction. Rotation. Rotation here. Elbow flex extension. What if I want to lengthen the triceps? Have to bring an arm over the edge of the bed if I have that kind of room, or I can do it in sitting and stretch out the triceps, the long head of the triceps. Okay. One of the things that you need to be cautious of in the upper extremities, depending on what muscles they have intact, is some of the hand muscles. Does everybody remember tenodesis? Remember Tina talk about tenodesis? What is that? Right. So when she when she extends, see how her fingers naturally flex. She doesn't have finger flexion or finger flexors, which she won't have unless she's below her injury level is below C8. That's when they have a complete upper extremity full hand grip. Then they need to rely, not C7, but C6 and C5, they need to rely on tenodesis for grasp. So you want to make sure when you're doing range of motion, unlike other people, when you're dealing with someone with a spinal cord that's going to need tenodesis, you do not want to do that. You don't want to do wrist extension and finger extension. You want to make sure that you're keeping that tenodesis there. So very careful. If I ask you this on a practical, it's not going to be on the midterm, but on the final, I'm going to be looking for you to do that. Okay, and maintain that tenodesis position.
So keep the fingers flexed.
Right, when she goes into extension, her fingers need to flex. Okay, and the goal is that over time they'll tighten, so that every time she extends, she'll actually develop a grasp that way. So it substitutes for the tightness, the contracture substitutes for the finger flexors, and she's actually able to grab a cup, she's able to grab a fork and feed herself by using those contractures. But if you stretch it out, she won't have it, and she won't have any grasp. Okay? So that's something that we need to be cautious of when we're stretching her. Otherwise, the range of motion would be the same. Just remember the scapula, because again, if it's flaccid and they're not moving there, you will bang away, and they may or may not feel it. Now, the other thing you need to remember is that if this person is a new injury, relatively new injury, and you're seeing them in the hospital, you need to be really careful about taking the upper extremities fully overhead unless you have permission to do so. And the reason why is, think about the nerve tension test that we've done on each other. If you're putting their arm in a position that's going to stretch some of those nerves, and those nerves are attached to the injured part of the spinal cord, you're pulling on the spinal cord, you could create more damage. So there are certain areas you need to be very cautious of. So when the therapist sends you in, you need to make sure what are the limitations for the passive range of motion. Am I allowed to go fully overhead? Am I going to pull on anything that I shouldn't be pulling on? Or if they have a cervical fusion, you're going to watch with cervical range of motion, because they're fused and they're not supposed to be moving in those areas. And usually they're in a halo and you can't move them. But just in case the surgeon hasn't put them in anything, then you don't go in there and start pulling on the surgical area. Okay, so you need to know those restrictions. As far as positioning, what position do you think you put them in a hospital bed? Where do you want the elbow? Right, you want the elbow extended. You want the fingers supported in a position such that you're not encouraging this again, so that you're keeping it in what they call a functional neutral position. So resting Sometimes they'll put a small washcloth in there just to hold the hand in this position, or a bolster with a hand support on it to keep the fingers from overextending. Okay, and the elbow extended. This is more comfortable than this, obviously, so pronation of the forearm. Okay. Arm supported out in this position. Head to neutral. What about the lower extremity? Lower extremity is pretty simple. You want to make sure that you're not hyperextending anything and that it's kept in a neutral position, that the foot is supported up in a neutral position and not dropping down in that areflexive period. Questions on that position? All right, so I just want to talk to you a little bit in the acute care. In the acute care setting, there are certain muscles, again, that we want to be cautious of pulling on, and again, it's because of neural tension. So, in general, you don't want to take straight leg raise more than 60 degrees if that is a precaution, and if they have a lumbar injury, you shouldn't do that. You shouldn't pull on the sciatic nerve. Okay, does that make sense?
Yeah.
Especially a lower injury. And then no hip flexion beyond 90 degrees, because that creates a posterior pelvic tilt in a lot of people and will pull on a lumbar spine surgical area or on those nerves. So you have to be cautious when you do your lower extremity range of motion and make sure that, that when you're doing hip flexion, that for now you're just going up to that 90-degree point and not going above, and then don't do that. Okay? You want to always just be bending the knee at the same time so that you're not getting into that position. Okay, and rotation. Does everybody understand why you don't want to do that? Okay. The other thing that you want to tighten, you want those finger flexors to tighten so you get tenodesis, but you want the low back muscles to tighten because that helps with sitting. If you have someone that has very stretched lower back muscles, when they get into a long sit or even a short sit position, they're not going to be able to hold themselves up. You want that area to get tight because that helps hold them up in a more erect posture. Okay, so areas where we want selective tightening, finger flexors and the low back area. Okay. All right, so why don't we work on the manual stretching. I want you to work on that side lying rotation for trunk strengthening. And just as a review, I want you to do the passive range of the upper extremity with mobilization of the scapula at the same time.